everyone for coming. For those on Zoom, we've got Deanna, Liv, and Dan and me in the room. So you can tell it's that time of year, the time of semester. I initially was hoping to have some new data to present today, but that has not worked out. I'm still collecting data. So I'm going to use this as an opportunity to present the last study I did for my PhD, looking at some different sort of beliefs that we might have about weight and its connection to health and how that might be influencing stigma and treatment approaches among healthcare professionals. So, is this working? Oh dear. No, we got it. It's good. Yeah, so that's basically what I'm going to talk about. I want to start by thanking the team that contributed to this project. It was a big effort. We collected this data during the peak of COVID. It took a year to collect. We were trying to recruit health professionals who were very overburdened at that time. And yeah, it was a big collective effort for data collection, analysis, the whole process. So I just want to recognize that. So just a real quick overview of some of the background that went into the research question for this study. So we know that there are several key assumptions that we have as a society about weight and health that are thought to be key in fueling weight stigma. The first is that belief that individuals have a high level of control over their weight, that weight is a reliable indicator of someone's health status. And then the third one there is that stigmatizing people who are high weight is an effective way of motivating them to engage in healthy behaviors and make positive changes with the assumption that they are not engaging in healthy behaviors to begin with. And a lot of, you can see evidence of these assumptions throughout so many aspects of our daily lives. Media is a huge one. And I think that notion of controllability and the link that we make between weight and health is just so obvious in like the language that we use, in how sort of, you know, health issues are promoted and the framing around we need people to be a healthy weight. So all of this stuff is just really, really apparent. And we know that weight stigma is really harmful. So just some of the negative stereotypes that come out of some of these beliefs that people have that then, you know, form part of what weight stigma looks like. These stereotypes are that high weight people are lazy, overindulgent, lack in self-control, and are sort of inherently unhealthy. And that little pie chart there is just 42% just from one survey that was US data, but data suggests that this is very similar in other kind of particularly Western countries, that approximately that's 40% of people who are high weight and that they have a BMI of 30 or above experience weight stigma and discrimination in their life. So it's really prevalent. And has a whole lot of negative health implications, as we all kind of know. I was jokingly saying before that I'll just make this section really brief, that stigma is bad and we can kind of move on, but I think it's important to highlight just how bad it is. Those are just some of the negative health implications. So it can be really distressing. It's been found to reduce people's self-esteem. It can also reduce people's feeling of their sort of capacity to self-regulate their food consumption, and also reduces motivation for engaging in healthy behaviors, which is really counter to that belief that we often see, that if we stigmatize people, they will engage in healthy behaviors, that they will change their behavior. The research suggests that that's just not the case. So yeah, so lots of different negative health implications. And we also know there's a lot of research now to show that healthcare and health professionals are a huge source of stigma. So health professionals have been found to spend less time with high weight patients, less willing to treat higher weight patients, They can often blame the patient for failing to lose weight and also for any of their other health concerns, rather than kind of looking beyond that. And often provide unsolicited weight management advice. So this is when a patient is seeking advice for some other kind of health concern, and during that consult, they are their weight and weight management is brought up by the healthcare professional. And if this is unsolicited and that the patient is not seeking that advice, it can be experienced as discriminatory. And we know that this, on top of all of those negative psychological and physiological outcomes that I've already touched on, we know that this can actually also lead patients to disengage from healthcare services. Why would they want to go back to a place that has caused them distress, and that they feel like they're not really treated fairly? And that can then have additional health implications for them if they're not engaging with healthcare services. So a lot of the research that's looked at trying to intervene and try to see how we can reduce stigma among healthcare providers has really focused on this first assumption. So trying to change the extent to which healthcare providers see weight as being within people's individual control. And often the way that they do this has been to provide them with information about other factors that we know can lead to weight gain and can determine the weight of an individual, that are considered sort of outside of personal control. And often they focus on things like genetics and sort of biological factors. But these studies for health professionals in particular, the results have been really mixed. So sometimes these studies will be successful in sort of reducing the extent to which healthcare providers or their participants endorse negative stereotypes or express weight stigma. Sometimes it can reduce some aspects of stigma, but not others. So for instance, it might reduce those sort of explicit anti-fat attitudes, like ideas about laziness and lacking self-control, but then might not actually influence other stereotypes that we often see in the healthcare context around beliefs about patients' sort of likelihood of adhering to treatment recommendations and those sort of more nuanced assumptions that are made about the patient. And then some studies have just found no effects. So to try to kind of understand why that might be happening, we can look at other contexts. So Nick Haslam and his colleagues have done a bit of work on the influence of, sort of providing people with these biogenetic causal explanations for mental illness, and have found that it really has mixed effects. And they call this like the mixed blessings model. So they found that providing a biogenetic causal explanation for mental illness can reduce stigma by reducing the blame that's placed on the individual with the mental illness, but it can also increase stigma or certain kinds of stigma, particularly things like negative stereotypes, because it might trigger essentialist thinking about the person. So the idea, essentialist thinking is basically seeing something as fixed, stable, and sort of defining that person's identity. And this can mean that those stereotypes that are attached to a particular mental illness, for example, can also become identity defining for the person that has that mental illness. And so it's through this, by triggering this sort of essentialist thinking, they propose that this can have that sort of opposite effect of increasing stigma. So we thought that perhaps this could be also happening in the context of weight stigma, and we sort of set out to try to explore this. And I just want to, so we did explore this in an experimental study with healthcare providers, and I just want to provide a bit more kind of context because we didn't manipulate the biogenetic causal explanations for higher weight. Instead, we focused on manipulating a different sort of way of thinking of, and we did use the term obesity here because it was with healthcare providers, and that is the medically accepted term, defined as having a BMI of 30 plus. But obviously it's in quotation marks there just to recognize that that in itself can be quite a stigmatizing term. So I try not to use that terminology as much as I can, but we did have to use it a bit here because of who we were recruiting and doing the study with. So to kind of, take a bit of a step back and give you an idea of the context behind what led me to also come to want to investigate this research question, I sort of was reading a lot about how different organizations around the world had been, over the last maybe 15 years or so, have been gradually making a move towards sort of formally classifying obesity as a chronic medical disease in and of itself. So we know that it's very much widely acknowledged and recognized, and we're told this all the time, that it is a risk factor for other diseases like diabetes, type 2 diabetes, like cardiovascular disease, also a risk factor for a number of different cancers, but it's not a medical disease in and of itself. But many medical associations and health bodies have been making this move towards recognizing it as a medical disease. And there are lots of arguments for why, and I'll go into that in a minute. But it's still an ongoing debate around the world. In Australia, they haven't made this move because the health expert advice was to not recognize it as a disease in and of itself. And the American Medical Association decided to recognize obesity as a disease against the advice of its medical experts. So this is still a contested issue. And some of the arguments sort of pro and against that have been given, those who think that we should recognize obesity as a disease think that by doing so, we might reduce weight stigma because they hope that it will reduce sort of perceptions about how controllable weight is, because kind of medicalizing it now, it's not a behavioral problem, and that this will then sort of reduce blame attributed to high weight people. And they hope that this will also improve quality of care for this population, in part because they argue that if it's a medical disease, then we can access more funding, subsidized evidence-based treatments could be a possibility. That's also why a lot of people don't want it to be classified as a disease, because that means more money going towards treating obesity. And I think there's a lot of stigma in that in some ways as well. But on the other hand, the arguments against it, a lot of people, and these arguments are coming from both health experts and people who are fat study scholars, who are advocates. So it's coming from a wide range of people. Many believe that it will actually increase stigma because it will reinforce negative stereotypes about high weight people, and that's sort of that essentialist thinking coming in. And that it'll reinforce that assumption that weight is an indicator of health, because now if you have a BMI of 30 or above, you now have a medical condition. And so it really kind of solidifies that idea that weight indicates someone's health status. And they also argue that it will increase focus on weight management rather than on health management. So it's now going to be all about getting the person to try to lose weight, as a proxy for, or as the kind of mechanism through which they improve their health, which is already happening, but many believe that this will just be increased. So those are the arguments that are being put forward. And so we kind of wanted to test this and see if getting health professionals to think about obesity as either being a disease or not a disease can this either reduce stigma? We didn't actually measure blame in this study because a lot of research has been done. That's why I've sort of faded out the second pathway there. A lot of work has already been done in understanding that pathway there, reducing stigma by reducing blame. But might it actually instead increase stigma by sort of triggering biogenetic beliefs, causal beliefs about weight, and triggering this essentialist thinking? Okay, I'm just going to quickly I just wanted to put that up to show that this has been tested in a study before with general population. They more looked at using, it says here their weight is unalterable message. So they basically provided participants with either a message about that the American Medical Association has decided to classify obesity as a medical disease. This is why, and sort of priming those beliefs about weight not being within individual control, or they gave people a message about how it is within individual control, and they did find some evidence to support this kind of mixed blessings model, which they called the obesity stigma asymmetry model. But it hasn't been looked at in health professionals. So we focused on indicators of these kind of outcomes here. So looking at stigma, looking at negative stereotyping is the way in which we sort of operationalized weight stigma, looking at people's beliefs about weight, including the extent to which they believe weight is an indicator of health or a heuristic of health, we called it, and their approach to treating a high weight patient. So we ended up with 365 healthcare providers or health professionals. Most of these, we made a real effort to try to recruit people who are either medical doctors or medical students or nurses or nursing students. So we were pretty successful, I think, in getting a decent amount of our sample from those professions. And I'd say about just over half were actually qualified working healthcare providers. So we used an experimental design here, and we, instead of presenting people with information and telling them that it is a disease or it's not, because we expected that we would probably get some reactance to that, we decided to use this alternative paradigm where we randomly assigned participants to either generate 3 arguments why it should be classified as a disease or 3 arguments why it shouldn't. And we made it pretty clear that this was like regardless of their own opinion, that we wanted them to try to think about these arguments, and then they wrote down 3 reasons why it should or should not. We then presented participants with a fictional, hypothetical patient's medical profile, which we created of this patient, Susan, who was presenting to a healthcare service because she had experienced 2 serious migraines recently, and she was seeking care for the migraines. Nothing mentioned there about seeking care for weight or weight management. The only indicators associated with weight was that we provided weight and height in the profile and a photo of the patient. In terms of her other sort of health status, she had no existing diagnoses or illnesses. Her cholesterol levels were normal. Her blood pressure was very slightly elevated, and everything else was, yeah, fairly healthy. So just the outcomes that we looked at. I realize I've been like standing in front of you, Dan, sorry. Yeah, so the way we measured weight stigmas, we looked at negative stereotypes of the patient. So the extent to which they believe that the patient was lazy, was overindulgent, those sort of classic stereotypes. We also asked them how they would go about treating this patient, and I'll tell you a bit more about that in a second. And we drew a couple outcomes out of those treatment responses. We measured biogenetic causal beliefs. So this was just with a single item from Nick Haslam's essentialist belief scale, which we adapted. And it just is the extent to which they agreed with the statement obesity is caused by biological factors such as genes and hormones. We assessed the extent to which they believed that weight was an indicator of health. And we also included a manipulation check where we, well, it's kind of like a persuasion check in some ways, the extent to which they themselves, at the end of the study, they themselves believed that obesity should be classified as a disease. And that sort of scale from 0, no, to 100, yes. So for the treatment decisions, we told participants that they could select any and all treatment decisions that they would make for this patient or recommendations from a list of 43 diagnostic and medical procedures. About 8 of those we identified as being based on previous research that's used this measure in a similar paradigm. 8 recommendations that were pretty specific to or relevant to treating someone for their migraines and less so for weight. 10 that were more specific to weight management, less so for migraines. Just important, I think, to also note that weight management or a lot of these recommendations in the weight column are not part of the best practice recommended guidelines for treating migraines, acute migraines in particular, which is why we chose migraines as well. And then the rest were just other different recommendations that they could make. Okay. I feel like I've just been going speed, speed, speed. Any questions? No? Oh, okay. All right, cool. Yeah, feel free to just interrupt me at any time. All right, so our manipulation check first. So we did see significant difference. So those who were asked to generate arguments for why obesity should be classified as a disease, they agreed significantly more that yes, it should be classified as a disease. So even though we were pretty clear that this was not about their own opinion at this when they did the actual manipulation, it seemed to have significantly shifted their own opinions, which we were very happy about. We were less happy about the fact that we didn't find too many effects, but what we did find is that those who conceptualized obesity as a disease, they agreed significantly more with that statement that obesity was caused by biogenetic factors or biological factors like genes and hormones. So they endorsed those biogenetic causal beliefs significantly more. Now, we didn't measure the extent to which they believed weight was within individual control, but I imagine we would have seen a reduction in that condition as well, because previous work has shown that believing in the sort of biogenetic causes means that people believe less in the sort of personal control that people have. We also, interestingly, found that those who thought about obesity as a disease made significantly more migraine-related treatment recommendations. So that's the proportion of available migraine-specific recommendations that they could have made, how many they actually made on average. And in the disease condition, they made 29% on average as opposed to 24%. Very, very slight, but statistically significant increase. And looking more closely, this was driven by one particular recommendation. They were more likely to prescribe pain medication for the patient. Not 100% why that's the case. I don't know if maybe thinking about like pathologizing the patient a bit more in some way meant that they just were more likely to go with medical treatment of some form rather than behavioral treatment. But we can't really tell what's going on there. We didn't find any effects on the extent to which they treated the patient for their weight. We did find that no matter what condition they were in, so across the two conditions, on average, our participants did provide a greater percentage of weight-related recommendations for the patient than they did their migraines. So I think it was 32% for weight and 26% for migraines, and that was a significant difference. So they were treating the patient for their weight more than they were for their presenting condition. And that was without the patient seeking that advice. So we wanted to look at now this is just correlational data. So looking at associations between our beliefs about weight and our outcomes of interest, so stigma and treatment approaches. And we found that the more our participants believed that obesity was caused by biogenetic causal factors, the less they stereotyped the patient. So that was quite positive. So that sort of lends some support to the notion that thinking about the biological causes of obesity might reduce weight stigma and possibly via that sort of reduction in blame. But again, this was correlational. And in case anyone's interested, we did find a significant mediation there. So that the indirect effect there was significant. Okay, this is the bit that I am like both angry with but excited about. So we found that the more that health professionals endorse the idea that weight is an indicator of health, the more they negatively stereotype the patient, the more they treated the patient for their weight, and the less they treated the patient for their migraines, for their presenting condition. Again, correlational, and we didn't have a significant effect of our manipulation on beliefs about weight as a heuristic for health. I will also say that generally, on average, our participants were scoring below the midpoint on this variable. So generally, they sort of were more likely to disagree that weight was a heuristic for health. So that was nice. And they also scored below the midpoint on weight stigma, negative stereotyping. But we see these pretty strong, significant correlations coming out here. And so that really, this is actually some of the first quantitative evidence that we have linking this belief that weight is an indicator of health to stigma and treatment approaches and treatment decisions that could be experienced as discriminatory by patients if they're not seeking that treatment. So just to sum up, how are we going for time? Oh, okay, good. Oh, I feel like I'm getting like hot because I'm just running through it. Okay. So yeah, so we made tentative conclusions from this research, and I think they do, as much as we would like to make some really nice, strong conclusions, we do have to be a little bit tentative, but I think it's still some really cool data. So it did seem that our manipulation was successful in shifting personal opinions. And it seems that conceptualizing obesity as a disease seems to increase the extent to which healthcare providers endorse biogenetic causal explanations for obesity, and correlational evidence, which is consistent with previous work, suggests that this might lead to a reduction in stigma. And I think that's really nice to see. But on the other hand, we did find that endorsing weight as a heuristic or an indicator for health could be perpetuating stigma. And I say could be, but I really feel like it is. I feel very strongly about this. So, but it's correlational, so we have to say could be perpetuating stigma and experiences of discriminatory treatment for higher weight patients accessing healthcare services. And so I think these findings have important implications for policy. And best practice guidelines tell healthcare providers to, if they have a patient who seems like they might be in those upper BMI ranges, to assess their BMI and to discuss weight management with them, regardless of the extent to which that person actually is seeking that advice. So it's very much seen as a sort of duty of care to do this. And I think policies that reinforce that link between weight and health could actually be potentially causing harm. Okay. And I don't think we can conclude either way whether formally recognizing obesity as a disease is going to actually have positive or negative implications based on this data. I believe that it's not something that we should be doing. I don't think it is going to have many benefits, if any, and it has a really high risk of harm. That's my personal opinion, but we can't make conclusions based on this data. But what I am really excited about is further exploring that link. So I think, it's this idea that weight and health are, they're almost seen as like one and the same thing, weight and health management. And particularly that link is really made for people who are high weight. And that's made very salient to them on a daily basis almost. And I think, it could be, I've got there, possibly this might be why our manipulation wasn't able to shift people's endorsement of weight as a heuristic for health, but maybe, these beliefs are pretty strong and perhaps difficult to shift. But I would like to explore possibilities of ways that we could shift. Is it possible to actually shift these beliefs? And so that's what I'm sort of playing with at the moment in terms of ideas of how I might go about doing that with some experimental studies. And this could be something for an honours student perhaps next year. I'm not too sure yet, but I'm really keen to hear anyone's thoughts. So I think the first question is, how do we shift people's beliefs about sort of this relationship between BMI specifically and health? Is providing them with information, challenging that association, is that enough? And what kind of, I suppose, moderators might exist here? So I think looking at the source is important. Is that information coming from a health expert? Is it coming from an in-group member? And I think in terms of like what that group would be, I think whether it's coming from a high weight person or someone who's not a high weight would be particularly important to look at. And that could have different implications depending on the audience as well. And then, yeah, and looking at, differences in, I think I've just said that, yeah. So I think that's something I'd like to explore. And then I suppose the next question is the consequences for it. Like, will it actually lead to reductions in stigma? Will it lead to reductions in how people perceive weight-based discrimination as being legitimate, because it often is seen as very legitimate? Will that reduce perceptions of legitimacy? I think Tina and I have briefly spoken about Michael's work on prejudice being seen as truth, and whether I think this belief might be something that could be driving the extent to which people see weight stigma or weight-based prejudice as truth rather than prejudice. So that could be interesting. And then looking particularly among health professionals, would this impact treatment approaches, or would we get like a reactance to this kind of information? And yeah, in terms of implications as well, I'd be really interested to look at, does this have implications for high weight people in terms of sort of social change, collective action? Does it have that, by challenging this belief, does that also, because it might challenge the legitimacy of discrimination, perhaps, could this then have potential health benefits for high weight people, because you're kind of challenging the idea that the discrimination that they experience is legitimate. So yeah, so those are just questions that I have and ideas that I'm sort of playing with at the moment. And I think I'll just probably leave it at that. I might leave the screen up so you can see my questions. Yeah, that might be nice, because they can't, I don't think they can see my face. I'm just a dark silhouette. Okay. I feel like hot and rum.
Up to you, really. Maybe. Hi, everyone. Welcome to the club. Yes, I'll try to do that without messing up the Zoom.
Oh, right.
That's what I'm a bit afraid of. I can just, actually, I could just close this.
Yeah, that's it.
There we go.
That way.
Can everyone hear us?
Yeah, we can hear you when you're kind of talking in the right direction.
Okay.
So yeah, I think it's okay.
Okay, I might yell then.
It's much better now the projector's off too, because it looked very strange for a moment there.
It's a weird world.
Can I sit here? Yeah. Hello. Now you can see me. I'm not just darkness.
We know what you look like, so we were able to sort of fill in the blanks. Yeah.
Yeah, I'm really keen to like any thoughts on the study that we did, or particularly on like where we go next with it.
My first big question is, did you brief the patients, the participants, or?
So it was all done online, but they did get a debrief sheet. Yeah.
Could it just be, like an ethical nightmare if you swayed their opinion on this matter?
Yeah.
In the direction that you think is like bad.
Yeah. I mean, it was a very slight change. But yeah, we did debrief them, and we gave them like contact details and references to papers and all that kind of stuff.
I have another question. I was wondering, so it looked like from the method slide that you got the BMI of the healthcare professionals. Have you looked at that as a moderator at all of any of the like effects?
I haven't looked at it as a moderator, no. I mean, I looked at correlations.
Okay.
And it correlated in the way that you would expect it to. So people with a high BMI endorsed that link between weight and health less, reported less stigma, that kind of stuff.
Okay.
But yeah, most like the average participants were in the like healthy or like ranges and the overweight ranges. So yeah, but I haven't looked at it as a moderator.
Yeah, I know there's like weight stigma is interesting because at least the very little I've read there, it like contact doesn't necessarily reduce it like it does with other types of stigma. People internalize it a lot more than other types of stigma. But I still think that like living as a fat person or a high weight person would like just tells you some of those things like intrinsically. So like it's genetic. You know that it's not necessarily like related to your health, even your health behaviors. So yeah, but I do think like there are obviously higher weight healthcare workers, but I guess mostly they're not. But I think that you could find that some of those relationships might be moderated or terminated through the
Yeah, because I mean it's published already, but that was probably
run
that analysis.
Keep digging.
Yeah. And
Uh,
we also have very thoughtful.
yeah, true. So I was thinking about your manipulation,
Yeah.
And you basically showed an effect on attitude, which is not 100% surprising given that you used an attitude change manipulation, right? So,
And that was what we were kind of
okay, so
trying to do without sort of creating reactance
yeah,
to it.
yeah.
Yeah.
So I guess two slightly related questions. The first one is how easy was it for participants to answer to these three things? Do you have any measure on any idea like how long it took them or anything like that?
I think the survey took people an hour, no more than 15 minutes.
Okay.
They could write as little or as much as they wanted, and it was up to 3 reasons. Well,
Okay,
But-
so they didn't
but
have to do that.
most people provided 3
Okay.
reasons, and some people wrote quite a bit.
Okay.
as well. Yeah.
Yeah, that's interesting because
I still want to actually look at like what they wrote.
Yeah.
Yeah.
As well. That data is still sitting there, and I've been meaning to get to it, but
one
yeah,
day.
one day.
I was just curious because like there's this strange relationship where sometimes the harder it is to come up with reasons. Once you come up with them, you're like, oh yeah, I guess I really believe that. So I was just wondering that. And the other, I guess, so the next challenge is then you change attitudes. Now, how do you change beliefs, right?
Yeah.
Is there any work on other forms of health beliefs that would be useful in this case? Like smoking. It's the opposite because, you're trying to convince people that smoking is actually unhealthy. But I wonder, like sunscreen, even vaccination stuff,
Yeah,
like how to change the beliefs of people. And like, I looked at some of this literature, it's a mess. Because it's hard to change beliefs.
yeah.
But there might be something interesting there when you're looking at other diseases.
Yeah. I mean, Tegan might have some thoughts on that, but I mean, the thing that still comes to my mind is that we really need to be changing like cultural norms, which is like our cultural beliefs about these things. And I think that's what's such a challenge here is that these beliefs are so ingrained.
Yeah.
Like we're just told this all the time. And so it's really difficult. So I think, yeah, if we can change attitudes, we're like, yay, we did something, but you're right, it's getting to that, like, actually changing people's beliefs is it's like advocacy. Maybe doing an experimental study is asking too much, but yeah, I haven't actually looked at other like health beliefs that too much to.
You'll find it's the
that.
same thing. It took decades, if not more, to change
Yeah,
attitudes
And that's
and
slow,
beliefs.
like cultural norm, right?
Exactly.
Yeah.
Yeah, exactly. So
So change.
yeah, so finding an intervention to change beliefs sounds both very promising and very difficult.
Yeah. Did you have any thoughts, Tegan?
Not really. I think I'd agree with you that I don't think conceptualizing these as individual level beliefs is super fruitful as a way forward, because I do think that people don't develop beliefs about particular kinds of other people in isolation. I do think that higher weight people are perceived to be a social group, both by other higher weight people and by non-higher weight people, and so these are intergroup beliefs. And sort of stereotypes and things rather than just being kind of individual attitudes, I suppose.
Yeah. Yeah, and there's the policy level as well, like that also needs to, and I wonder if that needs to change, like maybe that's the starting point, perhaps, is like changing, if you change policy, then you has that like flow-on effect to change norms, but yeah, I don't know. It's a really hard one because it's still so accepted. It's so ingrained. But yeah, but I've definitely becoming more and more interested in like the advocacy and like collective action side of things because I think that's where needs to increase. Yeah. And getting allies on board in like a helpful way. Yeah. Alicia, Keegan, do you have any questions or thoughts?
I was wondering, I guess it's not necessarily specifically related to your research. Sorry, there's a dog on under a dog here. Is there a lot of evidence that being a higher weight is a disease in a way that's not just like that society is not accommodating of people? Because I'm sure there's plenty of ways in which being a higher weight is, I guess, inconvenient or could affect your daily life. But I don't know, when you think about it, a lot of them are just that society is made for small people, I guess.
Yeah, I think that's one of the big arguments that a lot of health experts make against recognizing it as a disease, is that it doesn't actually meet the definition of a medical disease. It's a risk factor. But having a BMI above 30 is not in and of itself a disease. But some people make the argument that because of how many issues, how many health conditions it is a risk factor for, that in itself should be like qualify as enough reason to make it a disease in and of itself. But yeah, I think a lot of the argument is that it doesn't meet that definition.
I would add to that as well. I think that, there's our decision making in health professions about like what constitutes like disease or not is pretty messy anyway. And the most extreme example of that would be mental health, where, for a long time there was hope that, there would be biological kind of pathology found to underpin, these different kind of disease profiles that had been identified in terms of mental health. But that has come to nothing. Like by and large, there's been very, very little progress in actually identifying a kind of biological kind of set of markers for things like depression or schizophrenia or ADHD. It's like, no, it turns out people just fall on a spectrum with these things, and we pick these arbitrary cut points above which we kind of say there's a problem. And I think, to me, weight would be a very good example where it's like, clearly there are kind of, health issues that happen in a particular weight. I mean, I'm not saying there's no correlation at all, but that's not the same as saying that there's an inherent pathology that occurs above a particular weight that we could like identify and treat. I think that's a very kind of muddle-headed way of thinking about it.
Yeah, it is possible to have a higher BMI and still be metabolically healthy. And so if that is a possibility, then you can't then label that person as disease when there's no indication that they're unhealthy. So yeah.
And even that line of research about the obesity paradox, that's like, people with a certain like unhealthy BMI actually live longer than people with a lower BMI, and it's like, oh, why is that? Oh, so weird. It's like, it's only a paradox if you inherently believe that having a BMI is in itself going to kill you, not related to other factors that like, lead to a higher weight, or that can come from being a higher weight.
Yeah, exactly.
So it like affects the way that research is either focused or like the perspective that it comes from.
And I think like the intentions there are probably really like good, and that they're trying to challenge that notion, but it's still.
Yeah, it's like this thing exists and they're like, oh, that's like, subverting expectations. What's the weird thing going on here, rather than just treating it as a trend like any other.
Yeah.